Hello, my name is Jeremy Boroff, and welcome to my new YouTube channel. My goal is to get to 1,000 subscribers so I can offer a full PANCE and PANRE review course completely on a YouTube channel. Right now, I'm going to basically have free material, which is just a small portion of our course. And once I get to 1,000 subscribers, I can start offering a full course online here on my YouTube channel. So please feel free to share these videos with your friends, your physician assistant colleagues, and even people preparing to take the PANRE exam. Thank you. Now the first section on the cardiovascular section of the blueprint is over cardiomyopathy. There's 3 basic cardiomyopathies that you need to be familiar with when you're taking the NCCPA. Dilated cardiomyopathy, restrictive cardiomyopathy, and hypertrophic cardiomyopathy. Now, looking on the surface, each of one of them have their own intricacies and their own things worth remembering. Let's dive into dilated cardiomyopathy first. Dilated cardiomyopathy, it's important to point out, of the 3 cardiomyopathies that we're going to be concerned with for the exam, it's the only one that has systolic function that's impaired. It can involve one or both ventricles. Think of the ventricles as being enlarged and going from these really normal sized atria to these extra large ventricles, and kind of blood just kind of slushing around in them. The thing you have to be familiar with is the causes. Now, there's a huge laundry list of causes, and I would say in terms of the exam, what I would focus on is just being able to recognize these and pick them out, not necessarily have them memorized. They list the causes to be in genetic, thyrotoxicosis, starvation, it can be peri or postpartum, cobalt ingestion, sarcoidosis, radiation, hemochromatosis, thiamine deficiency, alcohol, catecholamine-induced, infectious, which can be viral, parasitic, and or radiation. Big picture item, I would just, point out that, this can be idiopathic, or it can be caused by ingestion of toxins or radiation or infection or metabolic disorders. When you look at a patient with dilated cardiomyopathy on physical exam, it's going to be similar to the patient, how they present with heart failure. The EKG, you would see some left ventricular hypertrophy or right ventricular hypertrophy. Of course, diagnosed by echocardiogram. The only thing that you consider is cardiac biopsy for is that those who suspect might have a treatable cause. Treatment is similar to heart failure, targeting increasing preload and decreasing afterload. So that's where the ACE inhibitors and beta blockers come in. Think of the ACE inhibitors as being these potent vasodilators that make it easier for the heart to pump the blood out, and reduction of things, and the beta blockers kind of slowing things down, so give the heart a chance to fill efficiently and make each beat more efficient, thereby improving preload. The next thing that we need to look at is hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, you got to think of it as this thickened interventricular septum that is basically causing outflow obstruction and diastolic dysfunction. It's almost like it's a stiff ventricle. It has a normal or small left ventricular size. The thing to remember about this, why it causes diastolic dysfunction, if you're going to detect a murmur on a physical exam, it's going to be a decrescendo systolic murmur. I would probably, in terms of the exam, I would probably just focus on it just being a systolic murmur, and you may have an S4 and S3 gallop, due to the ventricular stiffness problems that are associated with it. Another thing to remember about it, it's of all the cardiomyopathies, it's the most likely to cause life-threatening arrhythmias. Again, the most common symptom is dyspnea on exertion, similar to someone that would have, you would see with CHF too, but you don't have a lot of more of edema concerns on things like that. These patients also may have exertional chest pain rather than actual coronary artery disease, but due to the ventricular and septum impeding the blood flow out of the heart and decreasing the perfusion of the coronary arteries. Syncope or dizziness may be present, and that kind of makes sense. If you have a patient that's has basically a flow block or being slowed down or impaired coming out of the left side of the heart, the great vessels aren't going to be perfused as much, and thus decreasing cerebral perfusion. So another interesting side, these can also be asymptomatic. So you have a wide variety of symptomatology associated with it. They may not even have any symptoms, and they can have life-threatening arrhythmias and present with syncope or even exertional chest pain. And of course, with all cardiomyopathies, an echo is needed for diagnostic confirmation and to determine the severity. Typically, when you detect these, they're in older people that you may be considered with. You may be concerned for heart disease, so of course you'd have to do a catheter rule out concomitant heart disease, because it's possible to have more than one thing associated with it. Treatment is also targeting diastolic dysfunction. So beta blockers are good to treat. I misspoke. Calcium channel blockers are ideal. Calcium channel blockers in general, anytime there's any diastolic dysfunction, they improve improve things. Calcium channel blockers in general, dilate the arterial side, and they also have, because there's smooth muscle activity, relaxing the smooth muscles help improve diastolic dysfunction. Beta blockers can be used also to help increase preload and allow the ventricle to fill better. The next thing we need to do is switch gears and look at restrictive cardiomyopathy. This is the last one we need to talk about. Now, this one also has diastolic dysfunction. So, in terms of the exam, when you look at this, keeping your mind that it's restrictive and hypertrophic cardiomyopathy, the two cardiomyopathies that essentially we're dealing with the small ventricle. Those are both going to have diastolic dysfunction. So, dilated itself has systolic dysfunction. The curious thing about this cardiomyopathy is the systolic function is normal. The thing that I would keep in your back of your mind for the terms of the exam is amyloidosis is the leading cause. Again, with any of these, when we're looking at the causes of them, I would just I'm not necessarily trying to remember, in terms of the exam, the whole entire laundry list and be able to list them out. I'd be able to recognize them. And they're, the other causes is idiopathic. They can be idiopathic, be caused by sarcoidosis, hemochromatosis, radiation, scleroderma, and Gaucher's disease. With this type of cardiomyopathy, you're going to see right heart failure symptoms present, dilated neck veins, and sometimes you'll have to perform a right heart catheterization to make sure there's no evidence of constrictive pericarditis. These diagnoses are oftentimes difficult to separate. As with all the cardiomyopathies, as I said before, echo is needed to establish the diagnosis, and treatment is similar to those in heart failure. However, on this one, we tend to focus on, because there's no systolic dysfunction, but we're going to add diuretics to help decrease systemic vascular resistance. To sum things up, dilated cardiomyopathy, you see systolic dysfunction may affect one or both ventricles, and the chambers are large. Symptoms are similar to CHF. You have dilated chambers. Hypertrophic cardiomyopathy is a diastolic problem where you have small chambers, Remember, we're kind of, in terms of, for memory's sake, we're going to kind of almost relate this to restrictive cardiomyopathy. Both have small chambers, small ventricular chambers, and they both have diastolic dysfunction. But the thing to remember, hypertrophic cardiomyopathy, it has a systolic murmur associated with it. Can present as dystonia on exertion and chest pain with activity. Remember, this is the one where we have the thickened interventricular septum, sort of causing outflow obstruction. Restrictive cardiomyopathy, it's a diastolic problem, small chambers, right heart, elevated right heart pressures. Amyloidosis is the most common cause, and treatment is similar to heart failure. Only in this one, we're going to focus on decreasing systemic vascular resistance. Thank you. Now, the next thing we're going to look at in the cardiovascular section in the NCP blueprint is conduction disorders. Now, the first thing we want to look at is atrial fibrillation and atrial flutter. In terms of treatment, you want to look at atrial fibrillation and atrial flutter as basically the same thing. However, their rhythm's quite different. With atrial fibrillation, it is known as an irregular rhythm characteristically. So what that means is you're going to have irregular beats occurring at irregular times. The QRS complexes are not going to march out, and that's different from atrial flutter. I'll get to that in a minute. Atrial fibrillation is caused by rapid discharges of numerous ectopic foci in the atria. The rate of the atria discharges is approximately 350 to 450 per minute. These patients need to be anticoagulated, especially if it's going to be ongoing. If Coumadin is used, the goal on INR is between 2 to 3%. I'm sorry, 2 and 3. The reason for anticoagulation is because with atrial fibrillation, blood tends to be stagnant in the atria, and thrombi are known to develop, and this can put the patient at risk for, or does put the patient at risk for a stroke. Rate control is key. Cardizem, beta blockers, and digoxin are helpful. If you have a patient with AFib with RVR, ideally the best starting agent is cardizem, IV. Bolus ranges can go up to 20 milligrams IV. That's not necessarily, remember, for the boards, and we used to put them on a drip. Beta blockers can also help slow things down, and digoxin is also helpful for slowing things down. Digoxin, especially in the patient that have impaired ejection fraction, it's an inotrope, so it slows the heart down and makes the heartbeat stronger. A lot of these patients will have concomitant heart failure, so keep that in the back of your mind that digoxin might be an agent that's helpful to add, especially if someone that has associated congestive heart failure. The next thing is atrial flutter. Now, atrial flutter, I suggested, in terms of treatment, you need to think of it as it's basically the same rhythm. You can use it. All the agents we discussed about earlier, the cardizem IV, especially with atrial flutter with rapid ventricular response. Again, rate control is key. So any of the agents that I talked about before, cardizem, beta blockers, and digoxin are helpful. Digoxin for those that have congestive heart failure. Now, it is. The rhythm is very different, though. The QRS complexes are regular, and there's a sawtooth pattern of the that occurs at baseline. And when we talk about atrial flutter, we talk about conduction delay. So we have if we have two sawtooth bumps occurring between the QRS complexes, we refer to as a 2-to-1 conduction delay, and you can really see anywhere from the 2-to-1 conduction delay or 4-to-1 conduction delay. The conduction delay just refers to how many atria conduction occur to each ventricular conduction. Atrial rates fire at a rate of 250 to 350 per minute. I would, just in general, I would have in the back of my mind in terms of the PANCE, what the definition of flutter and what the definition of fibrillation is, and just have some idea that flutter means 200 discharges at 250 to 350 times a minute, and flutter occurs at a rate between 350 and 450. I'm sorry, fibrillation occurs between 350 and 450 per minute. Now let's move on to all the AV blocks. The AV blocks are a bit confusing, but there's just a few things you need to remember in terms of the PANCE for the AV blocks. With first degree AV block, let's talk about that one first. It's very simple. You just have a lengthened PR interval, and that's defined as being greater than 0.2 second or 0.2. The thing to remember about this is that it's no treatment's necessary. These patients are usually symptomatic, don't even know they have anything wrong with their heart, and it's basically something blocking the conduction through the AV node. There's no dropped QRS complexes is a key characteristic of this. How this would, you see this on the exam, is a simple rhythm strip. And have you identified that it's first degree AV block? So kind of get yourself familiar with that. I don't think you'll have any questions on necessarily the causes, but the PANCE has been known to surprise us from time to time. But I would be really surprised if you had anything else on this other than that. The next rhythm we need to talk about is second degree AV block. Now, this is also referred to as Wenckebach or Mobitz type 1. I know we attach different names to this, but in the answers, sometimes they won't give you a second degree type 1 AV block. They'll just give you Wenckebach, or they'll give you Mobitz type 1. So having that, you need to remember those synonyms. So have those in the back of your head. This is also characterized by lengthening QRS complexes, lengthening PR interval until the QRS complexes drops. So the PR interval is greater than 0.2. The rhythm usually doesn't cause symptoms. In these, we usually observe. The same thing attaches. I would just be able to identify this in terms of rhythm strip, not necessarily having any causes or treatment. Well, there really isn't any treatment other than just observation, especially in an asymptomatic patient. But just kind of have those things in your head in terms of the second degree type 1 AV block. The next rhythm we need to talk about is second degree type 2 AV block. It's characterized by a normal PR interval and dropped QRS complex. So you're going to find the PR intervals less than 0.2 seconds, and just have these random drop QRS complexes. It's also a Mobitz type 2. These are usually symptomatic and may be associated with syncope or near syncope, and can't predict the third degree AV block. I would remember that if the patient's on rate lowering medications, it's possible that these may play a role in it, so make sure that it's investigated. These can be present because of a lesion occurring in the coronary arteries. I know some people think purely as the electrical systems in the coronary arteries is two separate systems, but oftentimes when there's a problem with one, there can be a problem with the other. So especially in terms of that rhythm, if you see this rhythm, investigate coronary ischemia or infarction. So these patients should be admitted and really should have cardiology consultation for possible pacemaker. In terms of treatment, if you have a patient that's hypotensive, you probably should, or you should put them on an external pacer. until the cardiologist can take over. The other thing to remember is to have good IV access on these patients. The next thing we need to switch gears on is and talk about the third-degree AV block. It's also known as complete heart block. Now, this is kind of a no-brainer. These patients need pacers. In my 11 years in emergency medicine, it's interesting. These patients can walk around, just come in, be completely asymptomatic, and come in and you hook them up the monitor, a complete heart block. The key characteristic of these is that the P waves will march out and are equal distance from each other, and the QRS complexes are equal distance with calipers. So if you're trying to figure out if something's a first degree, second degree, or third degree AV block, you need to look at the P waves and march them out, and QRS complexes and march them out. If they march out and they don't seem to be interrelated, which is the definition of a third degree AV block, that's what it is. It's a third degree AV block. So none of the atrial impulses conduct to the ventricles. They're also referred to be as being dissociated. It can be caused from a congenital abnormality, infection, or post-op or structural problem. These patients usually do fine after you put a pacer in them. Now that's it. Now this next topic we're going to look at is congenital heart defects. Now, there's a few of the congenital heart defects that the PANCE focuses on in terms of their blueprint. We're going to go over those in just a second. I try to think of these in terms of the which ones are left to right shunts, where the defect's at, what that means, and what murmurs that they may have associated with that. Those are the things that you see to be repeated on the exams. The first thing is atrial septal defect. Now, it's caused by, as the name implies, it's caused by an opening between the right atrium and left atrium. It's known as an acyanotic heart defect, and it's a left to right shunt. Now, instead of remembering which one of these are left to right shunts and which ones are acyanotic heart defects, if you think about the physiology that's involved, the left heart has much more pressure than the right heart, so it seems intuitive that the blood would go from a higher pressure environment to a lower pressure environment. So if you think about the left side of the heart and right side of the heart being independent of each other, I think of the left side of the heart being oxygenated and the right side of the heart not being being deoxygenated blood. If you mix that with if you mix the oxygenated blood with the deoxygenated blood, it just makes sense that you're going to have a cyanotic heart defect. That you're not going to, you're going to be a little bit hypoxic, but it's not going to be as bad as purely mixing the deoxygenated blood, more of the deoxygenated blood in with the oxygenated blood, as we see with some of the other congenital disorders that we're not necessarily going to talk about today. Now, this one can have either a diastolic murmur and or a systolic murmur. Really not a good way to remember that. It's one of those things you just got to remember. I would not remember to get specific. I would just know it can have a diastolic or systolic murmur, not necessarily remember where it occurs in diastole or what type of systolic murmur occurs. I would just remember that it's a diastolic or systolic murmur. The next thing we're going to look at is coarctation of the aorta. Now, coarctation of the aorta, I just think of it as a narrowing of the aorta just below the origin of the left subclavian artery. You're going to have a systolic murmur present. And that kind of makes sense. You know, you'd expect someone with a coarctation aorta to have higher systemic vascular resistance, and during systole, when the blood's being pumped out of the left ventricle, it makes sense that there's going to be some turbulence associated with that. So you're going to have a systolic murmur. Now, on late cases, you're going to find elevated upper extremity pressures, and this will be different, or much higher than the lower extremities. They try to usually hold off repairing to stage 4 or 5. It can cause congestive heart failure, and that kind of makes sense. If you have a lesion on the left side of the heart blocking things, it makes sense that it's going to increase systemic vascular resistance, and it may increase left-sided heart pressures, and eventually perhaps cause elevated pulmonary vascular resistance. Sometimes you try to correct this with balloon arterioplasty, but not always successful, but that's usually the first approach. These patients should be on medications to, if needed, to help decrease systemic vascular resistance. This is also a cause of secondary hypertension. We'll get to later in another lesson. So the next disorder is a patent ductus arteriosus. This, as you remember from your physiology classes and anatomy classes, that the ductus arteriosus is a duct that occurs between the pulmonary artery and the aorta. And I think it's important to think of this communication that occurs after the pulmonary artery leaves the right ventricle. So what's going to happen is that the blood on the right side of the heart is going to be shunted to the left side of the heart after the child's born. Because remember, in utero, the right side of the heart right side of the heart pressures are higher than the left side heart pressures. It's inverse to what we have. We're not going to dive into part because it's kind of outside the scope of our conversation today, but it's known as a acyanotic left to right heart shunt, and it's left to right because once a child's born, there is higher pressures on the left-hand side and it's shunted to the right side, right-hand side. This is characteristic of a continuous murmur, meaning it occurs in systole and diastole both. The boards love to dwell on that. Indomethacin can be used to close this. It's usually the first step approach, and it exploits the mechanism of NSAIDs in that they inhibit prostaglandins. Now, if you think of prostaglandins, if you think of them as a potent vasodilator, and all of a sudden we're inhibiting that, indomethacin is helping with vasoconstriction, and sometimes we'll be successful in closing these PDAs with just some indomethacin. The next thing we're going to focus on is tetralogy to flow. Tetralogy to flow is a constellation of basically 4 things with a cyanotic heart defect. And with any laundry list that you're trying to remember for the boards, remember this is not a written memory test. It is a multiple choice test. So just keep these in the back of your head as far as being able to recognize them on a list in a question. So the 4 components of the cyanotic heart defect are restrictive VSD. So the VSD is big, and there's a severe right ventricular outflow obstruction. And because of the right ventricular outflow obstruction, you would expect to see some right ventricular hypertrophy. There's an overriding aortic root in the septum, so this really impedes blood making out of the heart. So this is why arrest at the heart. So this is why this is a cyanotic heart defect, is because blood's not making it into the lungs, not as much blood is making it to the lungs, and so the patient's going to be cyanotic. We think of it as a right-to-heart shunt, because we have this opening on the right ventricular side. Oftentimes, the pressure change that occurs after birth isn't able to because of the other physiology that's going on with this disorder. In these patients, it wouldn't be unusual to see digital clubbing or dyspnea on exertion. Digital clubbing, is something we see typically with chronic hypoxia. There's a surgery called a blade-like tussing shunt that it's a shunt we put in the great vessels to basically feed blood into the oxygenated blood in the left side of the heart, and sort of bypassing all this. We give most of these patients symptomatic and do need this surgery. The last congenital heart defect we're going to look at is ventricular septal defect. The thing to remember with this is most of these defects are small and close spontaneous without any surgical intervention. Larger defects can cause heart failure and will need surgical repair. And we're going to move on to the next topic. Thank you for your attention.